Hello, today I will be talking about pediatric airway anomalies and the noises they produce. The learner will be able to differentiate the different airway anomalies based on history, physical exam, and the sounds that they produce. As we get started, let's take a look at the basic airway anatomy of pediatric patients as it compares to adults. Compared to adults, pediatric patients have a floppier U-shaped epiglottis. They also have an airway that is more anterior and higher. The airway is more in the shape of a funnel, compared to an adult, which is more of a shape of a cylinder. These factors contribute to the many airway anomalies seen in children. When evaluating a patient with abnormal airway noises, it is important to look at the history. For birth history, was the baby premature? Did it have a strong cry after being born? What airway noises were heard? For age of onset, was it gradual? Has it been progressive, or did it come on suddenly? For quality, is it airway noise during inspiration, expiration, or is it biphasic? Also, is there any change with position, feeds, or is there any activity that makes the noise better or worse? You can also ask about their cry. Is it strong, weak? Is there hoarseness? Does the patient have cyanosis? Does the patient have history of previous intubation? Does the patient have reflux or aspiration? Or does the patient have history of cardiac or neurologic abnormalities? Physical exam can also help narrow the differential. You can observe if the sound occurs at rest or after stimulation, if there's any work of breathing, what's the character, quality, or severity of the noise or stridor, what is the anatomy of the oral cavity, and what is the alertness and muscular tone of the child. Basic evaluation starts with x-rays. Look at AP and lateral films to take a look at the larynx, subglottis, and the tracheal column. Another tool used by ENTs is a flexible fiber optic laryngoscopy to look at the nasal cavity, oropharynx, supraglottis, and larynx. Benefit is you don't require sedation and there's instant feedback. Upper airway endoscopy is also helpful when the diagnosis is unclear, if there is a subglottic lesion suspected or there is concern for a secondary airway lesion. You can do a scope from above with an FFL, a direct laryngoscopy, and a rigid bronchoscopy. Next, let's take a ride through the airway and see what noises we find. Our first stop will be the nose and the nasopharynx. The clues in the history will be snorting. Differentials for this include piriform aperture stenosis, choanal atresia, and craniofacial abnormalities. Choanal atresia presents with respiratory distress, cyanosis, and difficulty feeding. Clues to diagnosis include inability to pass a catheter through the nares. Diagnosis can be confirmed by axial CT, and treatment usually requires surgery. Congenital nasal piriform aperture stenosis is a fusion of the medial nasal processes at birth. Clinical picture includes respiratory distress, feeding difficulty, and cyanosis. Physical exam includes inability to pass a catheter through the nose. Imaging helps with a diagnosis. Management is usually conservative, with different feeding nipples, nasal decongestants, and corticosteroids. If that does not work, surgery is undertaken. Prognosis is very good and usually resolves as the child gets older. Next, we'll stop at the oropharynx and the hypopharynx. Here, the clues in the history could be gurgling and coughing. Differentials here include macroglossia, lingual thyroid, follicular cyst, and craniofacial abnormality. Our next stop is a supraglottic larynx. The clue here will be stridor. Differentials for this airway noise include laryngomalacia, laryngocele, or a saccular cyst. Laryngomalacia is the most common cause of congenital stridor and may manifest days to weeks after birth. Symptoms usually resolve by 12 to 18 months. Its pathophysiology can be seen as the epiglottis prolapses into the airway, causing blocked airflow into the larynx. Signs and symptoms include low-pitch fluttering, inspiratory stridor, that's exacerbated by crying, agitation, URI, or being in a supine position. It is improved with prone position and neck hyperextended. Reflux can increase the presence and severity of it. It rarely produces cyanosis. As seen in this picture, you can see how swollen the epiglottis is and how it's obstructing the vocal cords and air into the larynx. Management is usually self-limited in the majority of cases and resolves as the child gets older. Rare cases require surgery. Our next stop will be into the glottic larynx. Clues here include hoarseness and a weak cry. Clues here include a laryngeal cleft, a web or an atresia, or vocal cord paralysis. Vocal cord paralysis may be congenital or acquired. Etiologies include traumatic or iatrogenic procedures, including birth trauma, cardiac surgery, esophageal surgery, and intubation. Congenital abnormalities include cardiac anomalies and CNS anomalies. Evaluation is usually done through bronchoscopy. Our next stop is the subglottic larynx. Clues here are also hoarseness and a weak cry. Subglottic stenosis can be congenital or acquired. Acquired is the more common form. It's usually more severe and difficult to manage, and endotracheal intubation trauma is the most common cause. Clinical signs and symptoms vary based on the degree of stenosis. In severe stenosis, the infant may have stridor at birth. In mild stenosis, the stridor or airway noise may not manifest until a URI takes place. In acquired subglottic stenosis, in neonates, a clue to the diagnosis could be a failed extubation trial. In older children, you may be able to successfully extubate them, but they might present later with respiratory distress. Evaluation includes visualizing stenosis on plain films or a direct laryngoscopy or a tracheoscopy. Prevention includes using uncuffed or smaller size endotracheal tubes. Treatment options include endoscopic laser, anterior cricoid split to prevent the need for a tracheostomy. Our next stop will be the tracheobronchial tree. Clues in the history would be wheezing. Differentials here include a vascular ring, TE fistula, complete tracheal rings, bronchomalacia, and trachomalacia. Vascular causes include vascular ring, usually a double aortic arch, pulmonary artery sling, or an aberrant right subclavian artery. Symptoms are caused by compression of these vessels on the tracheobronchial tree. Presentation may be subtle. It can present as stridor that's biphasic or expiratory grunting. It can manifest as chronic cough, recurrent bronchitis, pneumonia, feeding difficulty, or failure to thrive. Plain films could be of limited value. Barium esophagram may reveal characteristic feeling defects. CT with contrast or MRI is a modality of choice. Bronchoscopy allows greater assessment of degree of compression, and treatment is usually surgery. Tracheomalacia is a congenital deformity of the tracheal rings. You'll hear expiratory stridor, wheezing, and cough causing respiratory distress. Diagnosis is made by flexible bronchoscopy with the patient awake. Collapse of the anterior tracheal wall against the membranous posterior portion is seen. Primary tracheomalacia usually resolves by 18 to 24 months. The severe form requires tracheostomy and positive pressure ventilation. Secondary tracheomalacia is caused by compression of vascular structures. Treatment is rarely needed as most are self-limited. In this picture, you can see how swollen and how compressed the trachea is. In bronchomalacia, the bronchus lacks rigidity. There's usually insufficient cartilage or there's external compression. You hear expiratory wheezing and stridor. It usually presents before 6 months of age and can be unilateral or bilateral. Symptoms decrease as the child grows older. In severe cases, a tracheostomy or positive ventilation or a stent might be required. History and physical are key in the diagnosis of pediatric airway anomalies. Airway endoscopy is also an important diagnostic tool. Proper management is possible only after a precise diagnosis has been established.